Evening, everybody. Thank you, everyone, for coming. Family, friends, colleagues. My name's Hashim Ahmed. I'm the Chair of Urology at Imperial. And it's a real pleasure for me to welcome you all here to listen to Professor Marcus Drake's inaugural lecture. My job is to not mess up the beginning and the end of this session, so I'll try not to say anything stupid, other than it was a real emotional event when we interviewed for Marcus's post, and a day that I will really remember for the rest of my life. So a real honor for him to be one of our colleagues, esteemed colleagues, an honor that we have Professor Paul Abrams here as well, so thank you for coming. And I don't think, well, you might do, as a family, know how brilliant and wonderful this man is. So you should be immensely proud, immensely proud. Thank you to the online audience for joining. Please do ask questions and write them in, and we will be having an opportunity to ask those questions to Professor Drake and questions here as well. If there is an emergency fire alarm, then you just have to follow the fire exits. I have to say that it sort of spoils the whole setting when you start talking about fires and emergency exits. But anyway, there we are. And then after this session, there are some drinks in the concourse, and we'll be directed to that. We will have some roving mics. So in the room, if you do have a question, please do wait for the mic to arrive before asking it, so that the online audience can hear what you're saying, and also it comes up on the recording. We are live streaming and recording, so if you don't want that, please walk out. But no, don't walk out. Marcus.
Thank you so much, Hashim. Thank you very much indeed, everybody, for being here. This is a midweek evening. It's very, very cold. So to have braved Transport for London, I really appreciate it very much. This is an emotional experience for me too. The interview was quite emotional. I was in floods of tears. But let's be perfectly honest. What we do is not really at an individual level, is it? We're not individuals going out doing brilliant things. We are teams. We egg each other on. We inspire each other. And it's an environment, not an individual, that drives this forward. And that's what I would suggest is one of the big messages this evening, is we need to talk together, and we need to improve things and constantly strive to do better. So, in our context, because I would actually point out there's a lot of medicine which focuses on things like cancer, understandably, dementia, things that people are frightened of. But in fact, the bladder is often poor relation, forgotten, and yet the experience, if you have a dodgy bladder, is very distressing. So let's come together on that subject, and let's try to promote an environment where people are not ashamed. They can come and talk about their bladder, their bowels, even their sexual, did I say sexual? They can talk about stuff and not be embarrassed. So in a previous life, I've come from Bristol. That's to the west. It's colder and wetter. That's why I'm here. But it was very nice in Bristol. It was very good. It was inspirational. And Paul, who will be speaking later, was a big part of this. He inspired the Certificate of Urodynamics, the International Consultation on Incontinence questionnaires, which are the leading patient-reported outcome measures. We also had our microbiology, and Paul's colleague, Roger Fenley, was very important in catheters, and that's driven through, as you'll see later. And we had a fantastic physiology department with Chris Fry. So it continues in great strength. There's Hashim, Andrew Gamy, Laura Thomas. This was a great environment to work in clinically, and academically outstanding. We had Athene Lane as a methodologist, and these individuals, there was Sam, Amanda, Jess, and Joe, giving their heart to drive through successful completion of studies like Upstream and Triumph. Sadly, Pursuit collapsed as a result of COVID. But we're going to be talking about all these and come to London. Because Bristol is an elite organisation which needs to spread its good practice to wider environments. And within London, you've got an ultimate platform to make a difference. So I'd like to consider some of the things that we can bring and some of the things that we can develop. For example, how can we do better clinical work? Our urodynamics, dealing with infections, dealing with spinal cord injury, that's SCI, and our flagship clinic, the Neurological Pelvic Organ Physiology Clinic. We will discuss each. We will think about our research opportunities. There's been so much dialogue that I've been able to enjoy already here, thinking about how to treat yourself with your urinary symptoms before coming to see the doctor, supporting the GPs, doing a better job of prostate enlargement, bearing in mind that King Charles may well want to be randomized into the study that we are leading, the PREMIS study. Assessing pelvic organ function, thinking about infections, bacteria, emerging collaborations. We'll cover these. But we have got to be honest. The challenges are considerable. We've got to work out what to do in a restricted funding environment when we're under strain because of administration, because of strikes, because of many challenges. We've got to do a better job on clarity of message. We're not so good at actually conveying the meaning of the research that we do. And unfortunately, I would say there is some need to change the culture. We can, and we have to. Now, in childhood, we potty train. We're very clever children. Once we learn to get control, we feel so proud. It is part of us that we can confidently do a talk, sit in a lecture, go and do activities, and not be incontinent. Unfortunately, it's vulnerable. There is a risk that you could lose continence, urinary, bowel, and other things. And this is a disaster. People stifle, they hide it, and they're afraid to disclose it to friends. They try and hide it from friends. Eventually, they may pluck up courage to come and see the doctor. But of course, they are shy. However, if they come to see the right doctor, that doctor may ask some sensible questions. They might manage to ask it without blushing. Do you ever have to rush to the toilet? How are your bowels doing? Any issues that we need to think about? Because bear in mind, these symptoms of urinary problems often coincide with other symptoms like bowel problems. So a good doctor can elicit these things from the patient and discuss frankly and just get these issues nicely catalogued without the patient having the ordeal of having to be forced to describe them and forcing the doctor to listen to these problems that matter to them. But I'm going to bring up our first need for culture change, because our ability to ask these questions is people like me. Many doctors dread the patients coming in and talking about such embarrassing things, the doctor gets embarrassed. And I think that that is a bad thing. We need to work out how we can make our colleagues better at discussing this sort of thing. Help them as well as help the patients. Now, why do we need to do this? It's because bladder problems are actually top of the list in many circumstances of the real disaster. For example, spinal cord injury, the top 3 health concerns to patients: bladder, pain, bowels. What do we learn in medical school? mobility, fear of the wheelchair. But actually, that's fourth place. These patients are more bothered by being smelly, by having nappies, by their skin breaking down as a result of constantly being wet. And even this, which was quite a considerate study, failed to consider properly the importance of sexual function to people. They do remain human. Let's acknowledge their humanity and discuss these things and aim to help. Now, being a little bit urological-centric to begin with, thinking about my own clinical specialty of urology, before we branch out, we manage the bladder problems quite simply. We need to assess properly. Take a good history, use some outcome measures. We need to make sure that behavioral advice is emphasized. Advice, education. Considerate use of medications, not too much, not too strong, checking if they work. Potentially, we might need to offer an intervention like an operation or something minimally invasive. But we're still not so good at working out what to do. And then there are issues of conveying a clear message. Now, let me exemplify that. The traditional approach, let's do a clinical study. And when we get the results, let's write up a paper, stick it in our specialist journal. There you go. That will sort out the problem, won't it? Everybody will read my paper, understand it, and adopt it into their practice. So here's an example. The upstream study, these are the 12 papers that came out of it. Now, realistically, you can't even read the 12 titles. We can't realistically expect people to read all 12 papers, assimilate, understand, and introduce that into practice. We really can't. Now, I was Impact Director at the Research Exercise Framework in Bristol, and that role is about teaching doctors how to get a message over with simplicity, clarity, and effectiveness. And Emma Cullen, there she is. Now, we spent a long time designing this. This is the distillation of all 12 papers into one slide that you can just have stuck to the wall of the examination room in clinic. Hey, Lena, let's stick it to the wall. And anybody seeing that, if they've had a little bit of introduction to it, knows how to manage, to emphasize whether symptoms are bothersome, what tests might be needed, and when. Any urological trainee, this is how to pass this element of FRCS urology. Next challenge. And again, Lena and Mary Joy, we've had a lot of fun really making sure that what we do in our urodynamic unit is elite. And it is. What Mary Joy in particular, when you do a study, sorry, she's blushing, don't be shy. What she's producing is first rate. All the parameters, according to the International Continence Society, are met. But many units around the country, they're not doing it to the same standard. They are failing to verify the key measurements. They just say, the report says this is the result, and not checking it. And about a quarter of the time, the result is wrong. If you just look at the report, you have to go to the traces and check it. They're not even maintaining the equipment according to manufacturer instructions. Well, come on. If you like doing an MOT, I like the fact that the brakes on my car work because I get them checked every year. If I didn't bother to check them for about 10 years, would you want a lift from me? So don't get your urodynamics done at a unit that hasn't calibrated their equipment or maintained it for 10 years. And unfortunately, we're not good on multidisciplinary. As doctors, we should talk to our nurses and we should engage to make sure the nurses are clear what we want, and then we should listen to them when they're describing it, and we talk. It's what we do, but many units do not. Let's change that, shall we? Now, this was a nice study. We just published this in the British Medical Journal. Very happy to have achieved the recruitment of 1,000 men who were randomized to receive a standardized, manualized intervention, which was an advice leaflet, skillfully written with excellent patient and public involvement. Either that or usual care, which is GPs did what they thought best. There was a significant difference in the symptom scores at 1 year, which is 9 months after the end of the intervention, and so it's an important study and one of which I am partly proud. Partly because disaster, in my view, we had 1% of the population non-white. We really need to try to work effectively to ensure that we are inclusive and diverse in our recruitment. Now, this was not a deliberate intention. We assumed that our recruitment would reflect the population where we were recruiting, and we were wrong. So, in redemption, we are running a study now in which we are trying to help women with bladder or bowel problems, or both, particularly those that are living in underserved communities where there is poor access to healthcare or indeed lack of trust in healthcare, to recruit them into a study in which we will offer them self-care considerately delivered with linguistic and cultural considerations emphasized in their own languages. Now, as you can imagine, that will be difficult. Now, luckily, the Imperial Clinical Trials Unit, the surgery division, Natalia, Nick, Sassy, this is an effective group, and we will be doing our best to deliver. And we need help and support, and any access to expertise and public involvement that might contribute, we'd love to hear from you. The premise trial. Now, this is a very important study. This is the archetypal surgical study. Surgical makes it, of course, difficult to recruit to because men can be reluctant to receive randomization to a treatment. But Paul has demonstrated that it is possible to recruit, to randomize, and to deliver a major complex study, and he was looking at stress incontinence in men. So, folks, we can do this. We can recruit to this study, and we can deliver an important, confident knowledge of whether prostate surgery is better in terms of symptoms, worse in terms of complications, what men prefer. And it's great, Chiwen, to have you here. We've also got Stephanie. We've got a very good team in which we can really look forward to effective recruitment if we back you up. And we must do. So, urology. Traditionally, I suspect, we tend to be a bit siloed into our own specialties. I know urology, and many people go into their specialty and sort of think, well, I don't need to know about renal medicine anymore, or neurology, or indeed cardiovascular. What's that got to do with me? Well, actually, it's potentially a bit more relevant than you think, and it is worth keeping your knowledge up. Because, here's an example. In my area, I see a lot of people that have to go to the toilet very often. Once you reach the age of 40, many of us end up going to the toilet a little bit more often than they used to during the night time. Now, sometimes that's mere effect of aging. It might be that you've had a little bit much fluid in the evening or whatever it is. But sometimes it reflects not a waterworks issue, a problem with your bladder, but that you're making a lot more urine than you used to. Now, scratch your heads a bit. What things cause you to make a lot of water? Maybe heart failure. You accumulate fluid in your legs. When you lie down, you get rid of the surplus fluid into the circulation. You'll pee it during the night. There's even kidney failure. That means your tubules can't concentrate the urine as well. Your urine's dilute, you make more pee. All sorts of hormone problems, diabetes of all sorts. There are several conditions. And so, the GPs seeing these patients, they have heard of nocturia from urology, they may think, let's send them to urology, failing to spot. Something else is actually going on. In urology, we know less about medicine than the GPs do. We're probably even worse at picking up these problems. Therefore, we're trying to help the GPs, and Austin, I've lost sight, oh, there's Austin. Austin heads the Self-Care Academic Research Unit. One of the big advantages of coming to Imperial College is the fact that self-care is a big priority, and it's led by a very effective team, with Austin being particularly hands-on in making a difference. We are developing together with Ava, who is the research associate driving this forward, developing materials to guide GPs to spot these problems before they get referred to urology, to make sure that the relevant specialty, if appropriate, sees that patient. And making it particularly easy by incorporating into the GP's software a pop-up. If the patient types in, if the GP types in nocturia, because that's what the patient said, a pop-up appears and you follow a link to get relevant information. And that makes it so much easier. And then we're introducing, through the Primary Care Research Network, an opportunity to test how the GPs and potentially the patients get on with this information. So we're conveying a clear message, adapting things to help where it's going to be helpful. Now, as if that wasn't complicated enough, my title is Professor of Neurological Urology. So it's about time we thought about the nervous system. So what have we got to work out? Your waterworks are not that simple. You do have the bladder. It's the reservoir. It stores the pee. It's able to store because there's another muscle, the sphincter, which stays shut unless you open it at the toilet. For the men, there's an additional muscle group, the bladder neck, which is crucial in sexual function because the urinary tract of men is genitourinary. It carries both the sexual and the bladder outlet. So you need to wire this up correctly. What's it got to do? Well, it needs to function right at each given moment. So, for example, at the moment, it is not appropriate for me to pass urine. The reason I know it's not appropriate right now is my brain is saying, there's people here. Don't pass urine, Marcus. I am obedient. So your brain considers your circumstances and it knows, well, this will all be over in half an hour, thank God. It makes plans. I'll wait. It then has to make sure that it's instructing the next level down, your brainstem, which conducts the process. Your brainstem at the moment is saying, bladder, shush, just store. Sphincter. So it's the conductor. And then, of course, it has the actual muscle instructions, the nerve groups that control the muscles, rather, different bits of the spinal cord. Each of those three centers has a different bit of spinal cord controlling it. Then there's wiring that goes from the spinal cord out to these organs, following various anatomical routes. And they're all a bit different, which gives us opportunity. So in summary, there is a central nervous system that I extracted. It has various key components. Think about each one. First one, oh, that slipped a bit, the periaqueductal grey. This gets a lot of sensory information. Sensory information that's all subconscious until the periaqueductal grey says, ooh, that one's a priority. Okay, brain, pay attention to whatever it thinks, which might be your bladder. Then there's the frontal cortex. This is your decision-making area, social appropriateness, planning, deciding whether to pass urine. That is in charge. It tells the brainstem, the one that coordinates, and then you've also got other bits of brain, the limbic cortex. I'm sure people are familiar with novels which say that somebody was incontinent as a result of something terrifying. Well, it's the limbic cortex that drives that. Interesting. Then your spinal centers, the sympathetic nucleus for the bladder neck, the parasympathetic for the bladder itself, and Onuf's nucleus for the sphincter. Now, neurological diseases can affect various bits of nervous system. Imagine that there was a problem that was affecting the periaqueductal grey. If the person wasn't killed by that, they may get increased sensation or reduced. Imagine the frontal cortex going wrong. If I had a frontal cortex problem, for example, some forms of dementia, I might start wetting the bed, or voiding dysregulation. That is literally passing urine in the middle of a conversation. I've seen it 3 times. It is a very dramatic experience to observe, and yet the patient was unfussed in each case. It's a remarkable thing. If you have a pontine micturition center, again, you might be not alive because this also controls breathing, but you would have problems passing urine. If you had a problem in the sympathetic spinal cord as a man, there might be problems with sexual function, specifically dry orgasm, unable to pass urine, or stress incontinence. You start to see that we can map and anticipate which bit has gone wrong according to the symptoms reported by the patient. I don't know what would happen if you knackered your limbic cortex or your anterior cingulate gyrus. It would be very nice if one of these clever neurologists could possibly tell us. He's hiding. Then what about the wires that go from the spinal cord to the organs themselves? In yellow, we've got the sympathetic nervous system running from thoracolumbar across the back of the abdomen towards the bladder and the organs there. We've got the parasympathetic in pink running around the rectum in this male patient towards the bladder. And we've got the pudendal nerve which runs past the anus along the ischiopubic ramus to the penis. In a female patient, we have got the equivalent, exactly the same, sympathetic, parasympathetic, having to skirt vagina, pudendal around the vestibule to the clitoris. And so we have got a nerve supply, parasympathetic to bladder and vagina. We've got the sympathetic, which supplies the kidney in both sexes, the testicle and the bladder neck. And then we have got the pudendal nerve, which supplies the penis, the anus, and the vestibule. We've got a wiring diagram. We can anticipate what will the problem be if something affects one of those structures. And we should be bearing in mind that all the pelvic organs have exactly the same supply. So you can start to anticipate if you damage one of these nerves, it's not only the bladder or the bladder neck that's going to be struggling, it's also going to be the vestibule or the anus or the vagina. You start to see patterns emerging which you can use to diagnose the nature of the problem. So, we are starting to really push forward on coming together as professionals to work in a multidisciplinary context and do a better job. And Emma Carrington, up there, my colorectal colleague, is a principal advocate and driver behind this as we work in partnership to do a better job of bringing bladder and bowel into the same consultation for these patients. And here we have a little manifesto. We should be talking together to do patient-centered care and research. We should manage all of these together, not, oh, go and see the gynecologist, and then when they've finished with you, go and see the colorectal surgeon. No, do them together. And above all, let's not be frightened about the really complex patients, because some of them are really complex. And rehabilitation, Mina over there has been fantastically supportive of pulling together an understanding of the consequences, for example, of head injury, things like that. And we're talking to try to do better. So here are our flagships, the Neurological Pelvic Organ Physiology Clinic. And I'm very grateful for the support that we've had from that, from David, I can't see David, Heroda, but Lawrence, David, fantastic, and George, Hannah, and all the administration team has really been trying hard to get this working, and the leadership has been very, very supportive. But I'm also very fond and grateful to the Pan-London Spinal Cord Injury Improvement Initiative, with Davina Richardson being incredibly important for pulling together a better job across London, and Imperial Healthcare Trust making a contribution to that. So what are we doing? In this clinic, we are pulling together urology, colorectal, physiotherapy, Colette, who's currently on maternity leave, Katie. We've got urogynecology, Alex Dajesu Al-Kabaid, andrology, Sammy, good lad. Neurology, Andrew McHattie, he's a registrar, but he has been so effective and valuable at really understanding what we need. All these, our intention is that all these will be present at these clinics, so the most complex patients will have the full assessment. And then, more widely, ward rounds or multidisciplinary. We've got rehabilitation with Mina, with Giselle, with Jonathan. We've got the HTLV clinic with Graham, with Nick, with Divya, with Jericho. We've got psychology, Agnes, Ali Mears and the female sexual clinic. Normal pressure hydrocephalus clinic with Chris Carswell. We've got pain and autonomic, that's in its early stages, but Harriet Kemp, Andrew Rice and Ian. We're talking to all these people within Imperial Healthcare Trust and wider across London. And there's animation and coming together and difference emerging. So our clinical developments are strong. They need to be. There's a big problem. For example, and this will be a bit of a shock, I will actually say that when a neurological examination is done, it's got a massive blind spot. Cranial nerve examination, brilliant. Limb examination, fantastic. Sacral, pelvic organs, well, they might notice that you've got an anus, but that's about the extent of it. They certainly don't notice whether there are any genitals. These are rather important. So I was talking about this to a neurosurgery registrar, Holly, and I said, well, isn't it a bit surprising? And she said to me, Marcus, don't expect a neurosurgeon to take a patient's trousers off. And I said, really? And she was then very emphatic, Marcus, do not expect a neurosurgeon to take a patient's trousers off. And now I've learnt the same applies to neurologists. So what are we going to do? We've got to deal with reality. We do not expect the trousers to come off. Now, does it matter? Yes, it does. Here's a medico-legal case. Inadequate assessment. Cauda equina syndrome, squashing of the lower end of the spinal cord, was missed. The examination was inadequate. Case closed, apart from a lot of arguing. So we should really be introducing new practice to encourage the entire profession to do a better job, the whole of medicine and nursing. So here's an example of perhaps a way to start thinking. Here is a 26-year-old man. He fell from quite a height. He banged his head and got bruising in the skull, and he fractured his pelvis. And he's got some symptoms. Where was the problem? Was it in the skull or in the pelvis? Well, by simply taking a history properly, we worked it out. We worked out his bladder sensation was bad, but he did get discomfort when his bladder was very full. That tells us his sympathetic nervous system is intact because it's the sympathetics that mediate pain. But the parasympathetics might be weak because they mediate your normal sensations. Then you've also got that he was continent. Therefore, his pudendal nerve must be intact because that supplies the sphincter. And then he can't pee very well. Again, parasympathetic. No other problems. So we know that this area, this awful broken pelvis, has cut off the parasympathetic nerves because they run around about there. The sympathetic nerves run at the back of the abdomen. They were undamaged, and he doesn't have any symptoms to indicate a brain problem. We know what's going on. And this is of practical use. So in neurosurgery, all the time you're coming up with questions like, should we operate? For example, on a prolapsed disc, or something like this horrendous-looking cyst, a Tarlov cyst at the bottom of the spinal cord, through which all these important nerves are running. We should be able to assess that properly and help neurosurgeons decide what to do. This could be useful, couldn't it? So how do we assess? Now, we should be doing a good job of mapping symptoms onto deficits, but it's actually quite difficult to ask the questions. It's also quite difficult for the patient to convey what they're experiencing. So Katie here is running a project within the NPOP clinic to talk to the patients, to identify their experience, and to come up with a coherent system which will help us to interrogate their symptoms and understand better what's going on. But that's only talking. We need to be aware as well that there are other opportunities other than the interview type research. So for example, we should really be thinking about whether people have got a complex problem or a risk of a complex problem, for example, if they were to undergo an operation in the future. So Neha Sira, who is a senior registrar in urology, she ran this consensus statement about bowel dysfunction because we use bowel segments to reconstruct the urinary tract. But if we do that without thinking about the effect on the bowel and the urinary tract, the patient could have an awful complication. So in the medium term, we're going to be talking about a much more detailed, sophisticated, investigation-driven, with scanning and neurophysiology, to think about the impact on this complicated nerve supply if somebody needs surgery for cancer, particularly if they also need radiotherapy or chemotherapy, because that can damage all your nerves. Well, of course, your past medical history might be relevant. So Sadaf, Rakesh, Harriet, we've got a group together to start discussing this, which we'll bring together in the near future. I'd be very keen to hear from any neurophysiologists that might be interested as well. You're very valuable people. Commonplace, urinary tract infections. These affect a lot of people, and they're very bad in certain contexts. For example, somebody with a renal transplant, if you get cystitis, That can be very damaging to the transplant function. It may never recover. So another clinical development led by Neil Duncan with Binvant and with Anand is to talk through the complexities of urinary tract infection, how to prevent, how to treat in renal transplant patients. And we're starting to develop another within urology to look at our complex urinary tract infections. We're quite lucky in Imperial because there is strength in microbiome research. Julian Marchesi, whom I met when I was still in Bristol some time ago, we were the first to identify that asymptomatic people with negative urine cultures, so sterile urine, you know what? There is bacterial nucleic acids present. So they have bacteria, we just don't pick them up. It raises a rather fun question. These bacteria, if they are truly present, maybe they express some interesting enzymes. After all, the bacteria would have to survive in an environment where there's very little food. So these bacteria may have the advantage, if they express the right enzymes, if they can extract sugars off any molecules in the urine. Now, the way our body detoxifies harmful substances like carcinogens is to stick a sugar on them. That makes them soluble, and then they appear in the urine, where they are stored for a while in the presence of these bacteria and potentially with these enzymes hunting that sugar. So could they take off the sugar, off that dangerous, toxic, carcinogenic substance, thereby exposing that patient to the risk of bladder cancer? It's a fun project. Julian, Rakesh, Hector, Kian and I were trying to get this funded. It's a bit hard work at the moment, eventually. Next grant, urine infections are really bad in certain contexts, and the next one is dementia. Just imagine somebody living with dementia goes and gets a urinary tract infection. Now, dementia reduces your sensations, so they may not be aware of anything wrong to begin with. And then, even if they did start to become aware, they may struggle to express themselves. They can't communicate right because of the dementia. And the result, consequently, is the infection eventually takes such bad hold that they're rendered septic, unable to cope at home, and hospitalized, needing much more aggressive treatment and potentially not quite returning to the level they previously were at. We would like to prevent such bad infections and their progression to becoming dependent on care or hospitalization. So with David Sharp, Paul Fremont and Rafaela, we're pulling together a study where we will randomize people to antibiotics, urinary antiseptics, or cranberry, and look to see how this affects these potentially bad events. And it's an interesting possibility that maybe this will be relevant in other neurological contexts, such as MS or Parkinson's disease. Keen to talk. Now, there's some more ideas coming over the horizon. We'll look at the first three. I'm trying to work with Melanie Chan on the fourth one to look at the genetic basis of rare urological conditions. Melanie is an academic nephrologist, and we hope that we can start to look at the genetic basis of some of these things that we see in our adolescent transition patients. It would also be nice to talk to interventional radiology to try to develop new approaches to managing stress incontinence in women, because there was such a bad scandal of mesh surgery when used in the vagina that we can't now use it. And women are now left with these obsolete, or we thought they were, operations that are quite brutal and are very unappealing. We need new options. So any innovation, let's attempt that. Dialogue's already started on things like looking at the physiological consequences of a slipped disc. Can we actually prevent pain and bladder dysfunction? So Simone Di Giovanni and Ahmed Ibrahim, who's a neurosurgeon, we're talking about that, but it's hard work to get it off the ground. This is a fun one. Normal pressure hydrocephalus, for example, is an example of a problem in the skull. You've got several circulations in the skull. For example, the CSF flows through. There's, of course, an arterial supply to the brain, and there are interstitial lymphatic channels that carry fluid around. Normally, these auto-regulate. They control the pressure and the volume so that when you change position, your brain doesn't get squashed. But if something goes wrong with one of those circulations, it's easy to imagine that a strong reaction would be generated by the body. I don't want my brain squashed. Therefore, it's possible that there's a reaction to offload fluid and to reduce the pressure or the volume in the skull, and doing so by increasing the rate of urine output. This idea came up because of normal pressure hydrocephalus. I saw 2 women with that who, when they lay down, that's when they started to produce urine, and their entire urine output was made when they were trying to sleep. And they didn't pee at all when upright. Therefore, we would love to test this hypothesis. Chris Carswell running the NPH clinic, we've started talking about that. Neurosurgery, again, this will be very relevant indeed. And then, last study, our good old classic Foley catheter. We'd love to get rid of it, to put it for more pleasant uses than sticking it in somebody's bladder. After all, it is a dreadful thing. The balloon holds a great pokey thing into the bladder wall where it gets blocked and is painful. So for the last 10 years, we've been working on this design, and we've finally done the first in human testing published last year, the Flume urinary catheter. It drains better and it doesn't stick in. We're hoping for a CE mark this year, and as soon as we get that, we can do a randomized trial of the Flume catheter against the Foley. Now, my wife, Peter, as you can see, she is an adrenaline junkie, thrill seeker. She married me because of my ability to innovate, and so I innovated a much more exciting form of Jenga. Just to be clear, that's not her. I've been incredibly grateful for the support over the years. You have been amazing, and I just can't understand how you tolerated me, but thanks. I'll give you a Christmas present. Together, we do share many things, and one of them is, slightly remarkably, we bought some woodland in Devon, 9 acres of ancient semi-natural woodland, and we've stuck a yurt up in it, 4 meters across. We can sleep and listen to the owls hunting during the night, or see the glade lit by starlight. It's got waterfalls. It gets interesting fungus. These are called fairy cups. Wild garlic all over the place. And it's a bluebell wood. It's kind of nice, isn't it, darling? Hands off, though. The wild garlic's all ours. And what do we like to do? Well, it's brilliant coming to London, where Dominic and Molly are now working. And we all love to go to good sport, live sport. And this is at the Velodrome with Dominic's girlfriend, Lissa, just last year. It's nice London, isn't it? And then doing the Pennine Way. I don't know how you put up with that one. I vowed when I was 12 that I'd do the Pennine Way. So we're picking off the stages, another 3 in May. The other thing I like to do is curl up with a good book. And Medicine in a Day is something that was written by 5th-year medical students at the University of Bristol during lockdown. And the lead author here, Berenice Armbruster, just pay attention to that name. I mean, it's a cool name in the first place, but she is going to go very far indeed. She drove this project with a lot of medical students led by her. She has helped substantially with the second book. And actually, we got fan mail from the first book. I'm looking forward to the second book almost as much as I used to look forward to Harry Potter coming out when I was a child. Fantastic feeling, I must say. There's 2 more in this series that we're starting to work on. So that's how I like to pass my spare time. Now, some final thanks. I'd like to thank, yes, it is you. Well spotted. My brother Lawrence and I with my father, sadly no longer here, but he would have loved this and he was a big support. And my mother on the right, Lawrence, you've not changed as much as I have. You've aged better, clearly. So she's listening, I hope, online from Gran Canaria, but she's not technically perfect, so she may need the recording subsequently. But she has been a fantastic support too. But then the other person I'd really like to thank is Lorna. Where's Lorna? Looking a bit shocked. Lorna is my PA, Hashim's PA, Rakesh's PA, and you've done so much, so thank you.
Oops, it would help if it didn't.
Thank you very much indeed. So I really appreciate everybody being here. I appreciate, Lorna, the efforts you put in, the organising team, the AV, people who've given up their evening. Thank you, because this is a topic that means so much. We have discussed our opportunities. They're very, very big, but we must talk together. So let's encourage and be kind. Thank you.
Fantastic. Thank you very much.
3 minutes late, I do apologise.
Brilliant. We could listen to it all evening, so thank you. It's amazing. So we'll take some questions. We'll try and alternate between online, nothing online, and in the room. So any questions? We have 2 roving mics. Emma.
Marcus, well, first of all, thank you for such a wonderful lecture, and also just allow me to say how amazing it's been to have you as a member of the team at Imperial. I'm very lucky to work with you, and I look forward to many years of successful collaborations to come. I thought that your comment about recruitment of patients and potentially the cultural aspects of symptoms, how people express their symptoms, how people might understand or feel or react to symptoms of bladder and bowel incontinence might differ. And also how people might feel when engaging in clinical research, because it's absolutely key, isn't it, that we are patient-centric and that our patients feel as though, from all cultures and from every walk of life, feel as though they can come to us with these problems. How are you going to tackle that big problem and close that cultural divide? And what do you need from the medical community to help you do that?
She doesn't ask simple questions.
No.
That's my problem.
I mean, generally, Emma, you're a fantastic colleague, but that particular question, one of the interesting experiences is just how the next generation of research is being led by women and by non-white people. So here I am as a white male. It is my responsibility to encourage people not to be concerned and to step aside where my presence will be unhelpful. So the can't ignore this anymore study, I'm not the chief investigator. It's Ifioma, because it would be inappropriate for old white male to lead that study. But it's great, because we will encourage Ifeoma, we will give her confidence. She will become part of the next wave of academic, in her case, gynecology. And that's how we've got to do this. We have to look right, we have to sound right, we have to be sensitive, we have to be asking ahead from advisors to make sure that we don't put our great big size 11s right in the middle. And that's our best prospect. Got to make it easy for people. So thank you for the question, but thank you more for being the collaborator that you are, because without you, NPOP is in trouble.
Anything else? Aha. All on this side, so this side needs to sort of...
Again, thank you very much for a very inspirational talk. I was wondering if you had any ideas on how to improve the assessment of the sacral segments from the multidisciplinary team.
Do you mean how we get the professions outside us to take this up?
Well, within certain specialties, so I'm thinking in neurosurgery, neurology, neurorehab, but physio and nurses, we tend not to assess the sacral segments, but as you say, we do the limb segments very well. I just wondered if you had any thoughts on that or experience in other sectors.
So the thought has to be, we've got to provide something that is practical and clear, and that people could actually pick up with minimum input from training. In effect, a self-contained thing that makes sense as soon as you read it. Now, we hope that Katie's work will catalyse this, and the more we work with this core need to make it simple and effective, our better chance that it will be. And we've got the platform, the International Continence Society. We're doing a book which is looking at how do you do these basics well. And I think a module in that for exactly what you describe is our best chance. It's a massive order. It's likely a 10-year project. Let's do it. We need to.
Thank you.
Another question there.
Oh, do you want to go there first?
No, just...
You've been amazing.
And then why don't
for
you
this,
just come
so
down and hand the mic here, please.
Thank you, Marcus. I really enjoyed it. And I also enjoy our ward rounds, and having you on the team's been fantastic for rehab. My question's about neurological urology as a specialty. I think there's only a few of you in the country.
Nick?
How many are there?
Well, it's me and Nick, isn't it?
So 2 in the room. How many are there in the UK? Do you guys talk to each other? And what's the future of that subspecialty?
It's tiny. It would be very nice if we could catalyse interest from our urological trainees, but there is quite a cancer focus, which makes some sense, quite a cancer demand from management, which makes it more difficult. So, to be frank, we're going to have to focus on individuals. Now, I mentioned Nehar. I'd be very hopeful that we can encourage Nehar to take up a neurological element when she becomes a consultant in the relatively near future, fingers crossed. But then we might need to be thinking about other specialties, in effect, leading a urological component. Somebody like Holly, the neurosurgeon, Matthew Smith, who's a neurologist looking at Parkinson's disease. There's a little core of maybe, and that might just be enough of a spark to have a little fire in a few years of people that do follow in our footsteps.
Does this thing work?
It does.
Okay. Thinking about somebody, speaking as somebody who works in medical education and I'm teaching clinical anatomy, have you found, therefore, it's a bit of a niche question, have you found that people with Korner-Aquinas syndrome are being missed?
Yes.
A lot, right.
Oh, absolutely.
It's
And I think it's much more, those two over there, as Spinal Cord Injury Initiative and Rehabilitation, we've got plenty to talk about.
Yeah.
It's
so
very much.
We need to stress it.
And we need to do better, don't we?
There's a friend of mine who's a GP, he didn't realise that he himself was suffering from it. And it was a physiotherapist who pointed it out. And so, as you say, we've got to get down on our hands and knees and examine.
Hadn't noticed a numb
No, exactly. The second thing I wanted to ask, because I'm very, very excited about that flume catheter, so that actually is taking off now, is it?
Yes, we'd stopped the study early because of the prototype manufacturing was not good enough. Now there is better prototype manufacturing, it's more reliable. So in the States, where they're less fussy, there's a lot of groundwork being done, and hopefully that will lead to a CE mark, in which case the randomized studies are possible.
Then all the junior doctors in the hospitals will be saluting you if that thing comes out, because that'll be absolutely marvellous. Yeah, well done.
That would be nice, wouldn't it?
Thank you.
There's a question here, and there's a question just at the top.
Thank you for the talk. It was very informative. For many men, their entry to this comes through, say, PSA tests. And I helped to run PSA tests the last time. We had 450 through in a day. Do you have any views on PSA tests? They've certainly got a bad reputation. And when we run them, very often we get a bit of flack from hospitals and doctors. But the consultant we work with, Chris Eden in Guildford, says if they can recommend another test that's equally good, let him know. He hasn't heard anything yet.
So, cancer test.
Yes.
Cancer professor. Knows, do you know about this?
A little bit, a little bit. It's very controversial, so, and I don't want to take away from the topic at hand, but thank you for the question. We can maybe chat during the drinks. Thank you.
It's not a quick answer.
Lena.
Thank you, Marcus. That was incredible, and I really enjoyed it a lot. And I could listen to you the whole evening, but unfortunately I might need to run to the loo, so I'm going to stop. What I wanted to ask is, you're doing quite a lot of clinics, I think, in Imperial as initiative. I just wanted to ask, do you plan to invest any ANPs? What do you think of nursing colleagues taking a role with as part of your clinics?
Absolutely gold dust. The more that we can get allied professionals leading in the clinical delivery and the academic side of things, the better. And there are several reasons, but key to this is that they really actually listen and they focus on what matters to the patient. And so the dialogue between a AHP and a patient tends to be very practical, very detailed, and hone in on what they're really bothered about, the patients. Any opportunity to get additional contribution would be great. And one of the things is that we could potentially have a nurse leading on nocturia assessment, just with a relatively simple pro forma of checking through particular points in history, medical background, perhaps a couple of observations like a bladder diary, and you could reach a putative diagnosis that could be passed back to the GP and could be profit-making as well as good for patients. So there is very good scope. If we can get the people and the support, then we escalate the reach of this clinic.
Fantastic. So on that note, I'm going to hand over to Professor Paul Abrams. We all stand on the shoulders of giants, and Paul Abrams is really one of the giants of urology internationally, and a real privilege to have here. So he will provide the closing remarks for
Thank you.
Marcus.
Well, I've been asked to give a vote of thanks, and I really don't know who I'm supposed to be thanking. Thanks to all of you, of course, as already said, and those that have joined us online. Our trust's very grateful that you took Marcus, because they always said, can no one rid us of this troublesome surgeon? They also appreciate, of course, it's brought their salary costs down because they've been able to replace him with a cheaper, younger consultant. I think we have to say thanks again to the Drake family and their role. I mean, I've known them since they were extremely small. And the main thing about children is, of course, that they keep people like Marcus with his feet on the ground. because there's no respect, is there? None. And that's entirely appropriate, because he gets enough respect from everywhere else. So I think, and of course, Marcus is very grateful to my wife, who gives counselling to Peter Drake whenever she gets a bit down because of what Marcus is up to. So there again, we've got this elaborate teamwork on a social basis. I think your talk was fantastic, and I think you won't be surprised that we do very careful scrutiny of performance in our courses. And Marcus is always equal first as a communicator. Because although he had a basic education in science, which is much better than most urologists, he spent a lot of time with a wonderful woman called Alison Brading in Oxford, and then with Jim Gillespie in Newcastle, where he did lots of basic science. That's a very important background to what he's doing now. But what he's doing now is really simple stuff. The stuff that everybody else ignored, the stuff that affects millions of people. But doctors tend to be interested in the minutiae, the rare things. They can make a name on that. Nurses and physios are much better. They take a much more holistic approach, which is why I think you're very sensible to build these teams with the nurses and the physios and the allied workers. So I think I would then like to finish really by saying thanks to Imperial, because I'm just amazed at what you've achieved in the last 18 months here. And that's been done with fantastic cooperation by your academic colleagues, but also everybody who's in this room, as Marcus goes around and points to you. I mean, he's built up all these teams, but this was fertile ground. You were all ready. We've lost him, you've gained him, but I think you have a lot of things we don't have. And one of the keys, I think, to this work is to reach people. And I say people because I mean people who don't even realize they're patients, but they have symptoms. So the emphasis on things like getting up at night. Well, if you live long enough, you'll be up at night. Everybody of 70 gets up at least once at night. Actually, a third of all people at 40 get up once at night. Overactive bladder. If you live long enough, you will have an overactive bladder. You'll have urgency, you'll have to rush to the loo, and sometimes you won't make it. These are really common conditions, and they've been ignored. And it requires this combination of nurses, physios, and doctors looking at these very important issues. And then your self-care unit, I think, will be key to all this. And I'm very impressed, because the government had an initiative. I didn't see who the self-care guru here was, but the government had an initiative with self-care some years ago. Then it all went quiet. They gave it up. Well, I'm glad you haven't given it up, because this is very, very important. And that's the only way that we're going to improve healthcare, is by getting patients, telling patients it's okay for you to take responsibility. You don't have to ask a doctor's permission to do this, that, and the other, and you can make your quality of life so much better. So I think, thanks, Marcus, for a fantastic talk. We need to get the students, and ICL perhaps can do this because you've obviously got the interest, train them. They spend hours doing communication skills. What the hell do they learn? They're still embarrassed to talk to a patient about bowel function, bladder function, and ask them if they have any trouble with their sex lives. So they must practice this, mustn't they, amongst themselves? Now, I don't know whether, the female medical students will want to ask the male medical students about their sex lives. There must be some way around it. It must be role acting in some way. But it's got to be done, because it's the embarrassment of the doctors that's the problem. I think that nurses aren't nearly so embarrassed. I'm not sure I can speak for physiotherapists. Anyway, I don't know whether I've given the right vote of thanks, but thank you for inviting me. It was a privilege to be here with you all, and I'm very impressed. Thank you.
Thank you for that. Thank you for coming. Thank you all for sparing your evening. These are all precious hours, and I know it's very cold outside on a winter's day, so we all appreciate you coming here. And those online, thank you for joining us. And finally, Marcus, thank you very much.
Thank you very much indeed, folks. A glass of wine.